Hello. So in this session, we will cover shock and its types. So yeah, my approach to shock is just understanding what's going on. When you understand the pathophysiology, and by the way, shock is very annoying in like the arrows. I know mostly all of us have phobias of arrows, but again, they're really easy if you just understand what's going on. So this is my main approach of this thing. And you absolutely have no reason to memorize the arrows. Just, I mean, in my opinion, it's a very dumb way to go over these things. So if you just understand what's going on and the concepts, you will get them very easily. So at first, we have to identify some indicators or some ground rules that we will use throughout all of these things. So at first, we have some concepts that we have to examine. So first, we have a central venous pressure, and it's called CVP, or central venous pressure. And this thing is just a measurement of how much pressure that you have in the central system or central venous system. Duh. But essentially what it means is how much blood is in here. By the way, we measure the central venous pressure by measuring how much blood is in the right atrium. It's also equal to the right atrial pressure. So, because as you know, right atrium, it's the last location where all of the venous blood reach. So all of the venous blood will reach to the right atrium, right? So if we measured like it's like the collection of all the venous blood. So if we, and this is important because this way we can examine what's going on in the body. Like if we have low blood in the veins, if we measure its central venous pressure, it will be low, right? Because then we will have, if you have less venous blood and less blood overall, you have less blood reaching the right atrium, and then you will have less central venous pressure. So it's a cool way to identify if we have good pressure or not. And this is the first stage, by the way. So the first stage is blood going from the veins into the right atrium, then to the right ventricle, and then be pushed through the pulmonary artery, then reach the lungs, and then from the lungs through the pulmonary veins, then from the pulmonary veins into the left side of the heart, and then into the aorta. So the first stage is from the veins into the right atrium. And then we identified the indicator, the first indicator of this first stage, which is the central venous pressure. Next thing is pulmonary capillary wedge pressure. And this seems very complicated, and it complicates a lot of, annoys a lot of students, but it's actually a very simple concept. And it's just the name that seems complicated because it means pulmonary capillary wedge pressure. Essentially what does this mean is we get just some catheter, we enter the veins, and then we get to the right atrium, we get to the right ventricle, we go upward to the pulmonary artery, we reach the pulmonary veins, and we measure the pressure inside these pulmonary veins. By the way, if you notice here, the pulmonary veins will get blood again to the left atrium, and the good thing is our left atrium, the pressure inside this left atrium here, it actually equals the pressure inside the pulmonary veins, because some physics tells us that if you have like two containers, like the left atrium and the pulmonary veins, in direct contact with no things between them, or no obstacles, so you will have same pressure in both of them because you have same volume. That's it. So left atrial pressure equals to pulmonary venous pressure, and this is a cool way to indirectly measure how much blood do we have in the left atrium. So we get this catheter here, we measure the blood, the pressure in the pulmonary veins, and then it's like a reading, an indicator of how much pressure do we have in the left atrium. That's it. This is the pulmonary capillary wedge pressure. Next thing on our menu here is Yeah, this is pulmonary capillary pressure, and it coincides here, by the way. This is lungs, and then this is pulmonary veins, and this is reaching the left atrium here. So we measure it in this location here, pulmonary veins. This is the second stage. Third stage is left side of the heart itself. And as you know, left side of the heart, or the left ventricle, is the main pump in our heart. This is the big guns that we have. And it controls how much blood is pumped. And yeah, we have a measurement, it's called, or an indicator, which is called the cardiac output. And by the way, the cardiac output is equal to stroke volume multiplied by heart rate. And stroke volume is depending mainly on how much blood you have inside your left side of the heart, or volume of the heart, multiplied by how many, or how often does the heart contract, right? So that's the cardiac output. And yeah, if we measure the cardiac output, we measure it like in a minute. So it's how much blood is being pumped in a minute, right? That's it. Next thing is, and this coincides with again the third stage, or third, yeah, here. Last thing is in the aorta itself, because by the way, we use an indicator for like the vessels, and how are the vessels going. So if we measured, like, by the way, also an important concept, which is the blood pressure. Our blood pressure, like inside a container, the pressure inside this container or the vessel is done by, or controlled by, how much volume of blood you have inside and how much pressure inside, and how much the walls are, like how much pressure the walls are exerting. So you have two sources of pressure, like the blood itself are pushing and the walls are pushing. So you have two components, and these they control like the blood pressure thing. So, and that's why the blood pressure is depending on how much cardiac output do you have, because this determines how much volume do you have. Next thing is how much pressure do you have, and the pressure, or also called resistance, also controls the amount of pressure do you have. And this is very, very important, very crucial concept to understand. So systemic vascular resistance is like a way for us to see how much like pressure does the vessel exerts on the blood, or how much resistance do we have. That's it. Yeah, and this is the fourth stage here. So that's it. Let's just get into our types of shock. So again, my approach is just understanding what goes on, and this will actually help you a lot through your questions and through your word. And yeah, so let's just get rid of these. That's it. So let's start with the first thing, and the first thing is hypovolemic shock. And actually, if you want to understand or learn something, or learn a concept, just try to decipher the name. The name actually tells you a lot. By the way, like one last thing before we dig in, which is the sensors. Our body is very, very smart. Thank God. It's designed in a way to really control anything that happens. And this is very, very cool, because as an example here, we have some volume sensors, and we have two of them. We have one in the carotid, called carotid bodies. We have one in the aortic arch, and these again are volume sensors. They sense how much volume do we have inside of our body, because these set things straight and keeps things in the normal like phase. So let's see what happens. So the carotid bodies, and yeah, when they see more volume, when you have a lot of volume in your or blood volume, they do an important thing, which is you stretch these things here. Because when you have a lot of volume, you stretch the aortic arch as an example, or you stretch the carotids. So stretching here means activating these things and making them work more. Yeah. So since they work more and stretch more, they do what's called more firing. Because from these two locations, you have two nerves. The cranial nerve number 9, the glossopharyngeal nerve, and 10, the vagus. Both of them carry some information and some neural signals into the brainstem, and this will control the scenarios. And mainly what they do is when they are activated and fire more through these nerves, they activate more the parasympathetic. And also, if you know, sympathetic. So the parasympathetic, it relaxes organs like the heart, so it will cause less heart rate, and it relaxes everything. So as an example here, if you have more volume, in order to get this thing straight and compensate, you have to activate the parasympathetic more to get less heart rate and control the heart rate to be able to have normal blood pressure. So, because if you remember, cardiac output is equal to stroke volume, which is mainly affected by volume. So if you have more here, we have to get the low heart rate to be able to have normal cardiac output. Right? That's it. And the opposite is also very important. And actually, it's more important even. When you have less volume, these receptors are actually less stretched because you have less volume, because when the blood itself, it stretches these. And when you have less blood, it will have less stretching and less firing. This means less activation of the parasympathetic. And when you have less activation of the parasympathetic, this means the sympathetic system takes over. The sympathetic is just waiting around the corner to have the chance to overcome this parasympathetic. So when it overcomes and takes the upper hand, it will do the opposite, activating the heart, increasing heart rate and heart functions, yeah, and also activating the vessels and causing vasoconstriction. Because again, by the way, the blood pressure is very crucial, by the way, to control it. Like when you have less volume, of course, you will have hypotension, right? Because again, it depends, the blood pressure depends on how cardiac output multiplied by systemic vascular resistance, or yeah, these two concepts. So yeah, and when you have less volume in the blood, you have to be able to exert some resistance and some vasoconstriction in the vessels to be able to maintain the blood pressure, and also called perfusion pressure. Because we're trying here to maintain the perfusion in the organs. This is very, very important. Perfusion in organs. Because we're trying to save organs. And we save them actually by causing some vasoconstriction to keep the pressure back again. And it's important to perfuse organs well. Yeah, that's it. This is very, very crucial things. It will help us a lot. So let's get back and see what happens here. So we have, if you have hypovolemic shock, you have less blood inside your vessels. This means you have less blood going from the veins back into your right side of the heart, and this means when you measure the right atrial pressure and the central venous pressure, it will be low because you have less volume. And since you have less volume in the right side, you have less volume flowing through the pulmonary artery and then to the lungs. And this also means less blood going to the pulmonary veins and to the left side of the heart. And this means, since you have less volume in the pulmonary veins, this means you have less pulmonary capillary wedge pressure. It makes sense. Less blood is being transferred into the left side of the heart. Yeah, so the pulmonary capillary wedge pressure also decreases. Next thing is left side of the heart. It receives less volume. And since it receives less volume, it actually will pump less. Yeah, because if you decrease the amount of blood inside the left side of the heart, means it will push less volume. Makes sense. So this means less cardiac output, because cardiac output depends on stroke volume multiplied by heart rate. If you decrease stroke volume, this will decrease cardiac output. So last thing is systemic vascular resistance. And again, this all depends on the sensors that we just described. So since you have less blood and less volume, this means you have less activation of carotid and aortic arch, less parasympathetic activation. This means more sympathetic activation, and this creates vasoconstriction in the vessels and more systemic vascular resistance, right? And this will actually be very, very obvious. It will create a cold skin. Yeah. And yeah, let's continue. Also, the sympathetic system will also try to compensate by activating the heart, so it will create, will try to increase the heart rate a little bit. That's why the pulse is high when you have hemorrhage, as an example. By the way, causes of hypovolemia can be like hemorrhage, like dehydration for some reason. Yeah, mainly decreasing the amount of blood that you have. And by the way, all of them you will have high pulse or high heart rate to be able to get the cardiac output back up. Yeah, that's it. Next thing is obstructive shock. And again, same concept. If you want to understand something, you have to be able to decipher the name. And the name means obstruction, obstructive shock. So where is it obstructed, or what obstruction do we talk about? Coming right up. So obstruction essentially means at the level of, let's just do the cardiac output equation again, sorry. So cardiac output equals to, let's do it here, cardiac output equals to stroke volume multiplied by heart rate. And this is the blood pressure, it depends on cardiac output and stroke and systemic vascular resistance. So let's get back. Obstructive shock means there is some sort of obstruction, and the obstruction, from its name, it's obstructing, and mainly it's obstructing this area here, obstructing at the level of the pulmonary artery. This is the pulmonary vein, by the way. So obstructing at the way of the pulmonary artery, and if you notice, this is obstructing the way from right side of the heart into the lungs and then into the left side of the heart, right? So you have no blood flowing from the right side into the pulmonary artery, and blood will accumulate here. It doesn't go up, so it will just stay there. And essentially, actually, it does not stay there, because this is a very small space for the blood to keep here. They will actually backflow and backflow all over. They actually, as an example, accumulate in the right atrium here, and that's why we have high right atrial pressure and high central venous pressure, right? Also, it will accumulate in the veins themselves, so they will have like edema and other stuff. And yeah, this is like the symptoms of classic right-sided heart failure, because you have a lot of accumulation and backflowing of blood. That's it. And since blood isn't flowing to the lungs, so you will have less blood flowing also from the lungs to the pulmonary veins, and less blood in the pulmonary veins. This means, here by the way, in obstructive shock you have high central venous pressure, but again, less blood reaching the pulmonary veins, so pulmonary capillary wedge pressure is actually low. Yeah, that's it. Next thing is level of the heart. So since also we have less blood flowing to the pulmonary veins, also we have less blood flowing to the left side of the heart. This means to differentiate between here, and this means less blood here, so less blood being pushed, and you will eventually have less cardiac output because you have less stroke volume, right? That's it. So decreased, this will be also decreased, and it will be decreased. Yeah. Last thing is the fourth stage, which is a systemic vascular resistance. And since you have less cardiac output, blood pressure will go down, a hypotension, and you will activate the sympathetic system. It will do the same effect, causing vasoconstriction in the vessels and increasing the systemic vascular resistance, just as hypovolemic shock. And you will have cold, clammy skin or cold skin. That's it. Coming right up is cardiogenic, and if you notice, like cardiogenic, it's coming from the cardio, like coming from the heart. And again, the main side of the heart is the left side. This is the main pump. This is the big guns. Again, so cardiogenic shock refers to a problem essentially to the left side of the heart, like a problem in this stage here. So if you have a problem in the left side of the heart, like as an example, you had a myocardial infarction, you had a cardiomyopathy, you had something wrong or systolic heart failure. Yeah, something wrong with the left side of the heart. It can't pump. It's weak. It can't pump. So since it can't pump, can produce blood into the aorta. This means less blood output and less cardiac output. This is the main problem. And since you have less cardiac output, here this is the main problem. Of course, you will have hypotension, and yeah. And this hypotension will of course also activate the sympathetic system and will cause also high systemic vascular resistance to try to compensate and get the blood pressure back up. Also, a very, very important thing is, since blood can go out, let's remove one of these. So since blood isn't going out, again, the left side of the heart is a small container. It won't contain this much blood accumulating here because blood isn't going out. Closed way. So this means blood is accumulating and backflowing. And as an example, it backflows to the pulmonary veins, backflows to the lungs, backflows to the right side of the heart. It backflows everywhere backward. Right? Doesn't go forward, it goes backward because there is nowhere else to go. Yeah. So it goes backward. As an example, it increases the amount of blood in the pulmonary veins, and when we measure the pressure here, you will have high pulmonary capillary wedge pressure. And if you notice, the only way to get high pulmonary capillary wedge pressure is if you have a heart problem. This is very, very crucial. This is like a key word. If you notice or see a high pulmonary capillary wedge pressure, this means something wrong with your left heart. Hands down. There is nothing else that can do this. And all of the rest is low pulmonary capillary wedge pressure. That's it. Next thing is, since you accumulate also blood in the lungs, this will create pulmonary edema and orthopnea, or inability to sleep flat. Also, since blood is accumulating in the right side of the heart, this will create high central venous pressure. Yeah, it's like obstructing, because since left side of the heart can get blood forward, it can't really accept new blood, so new blood will accumulate here. So it accumulates here, and also it creates accumulation in the right atrium, and also in all the veins. And that's why, by the way, when you have a left-sided heart failure, eventually it will eventually cause right-sided heart failure, because yeah, blood has nowhere to go except for the way of the lungs and then to the right side. Yeah, it's a continuous system. Nothing goes, like, it won't be sucked out for no reason. Yeah, that's it. This is the last one here. And if you notice from here, there is no reason to memorize any arrows. It's just pure understanding. Just what you will really have to know is just what do these concepts or indicators mean, like systemic vascular resistance, cardiac output, pulmonary capillary wedge pressure. If you know what do they mean, you will get things right. That's it. And yeah, let's do the last one, and the last one is distributive shock or anaphylactic shock. So let's do it upward. And essentially, distributive shock, yeah, it's a problem in the distribution, and what controls distribution is actually the vessels. So we assume it's a problem in the vessels. Yeah, and it's right. And you have like a lot of problems can cause distributive shock. Like if you have like a neurogenic shock, if you have a septic shock, but essentially what really is obvious is the septic shock. Septic shock means you have some infection, some very bad, like a dangerous infection, and you have sepsis in the blood. Like toxins and bacteria are in the blood, and these toxins are very dangerous and very nasty, and they do two main effects. First, they interfere with your vessels and prevent like the resistance or the tone in the vessels, which cause less tone in the vessels. This means vasodilate them. Tone is like contraction. If you lose your contraction tone, this creates vasodilation, and very, very dangerous vasodilation. This vasodilation is very severe. The cause is actually hypotension. Because again, blood pressure depends on two things: amount of blood and the amount of resistance. If you decrease systemic vascular resistance by vasodilation, this creates low blood pressure and hypotension, right? So next thing is, since you have hypotension, and also next thing that the sepsis does is, or the toxins does, of the bacteria, they also interfere with another thing, which is the mitochondria. Because all the tissues have mitochondria inside of them, and these mitochondria are the energy like house energy warehouse. So these are very important to provide like the tissues with energy, and what they need is oxygen. So they need oxygen in order to operate and in order to get ATP. And by the way, we have another concept or an indicator. It's called SVO2, and this SVO2 is like a measurement of how much O2 we have in the veins, or how much O2 we have in the blood. It's like the saturation of O2. How much blood is being saturated with oxygen, right? So again, our mitochondria is necessary to get oxygen from the arteries or the blood, and then use this oxygen to get ATP, right? This is the only reason to use oxygen, and that's why oxygen is keeping us alive, keeping the mitochondria working and keeping the electron transport chain, and then keeping everything going and then produce ATP and live. Yeah, need it. So since toxins actually injure the mitochondria, they injure the oxygen extraction and the usage of oxygen. This results in no oxygen usage, and this means oxygen is just sitting there. It's accumulating and sitting there, not functioning or not doing anything. This results in higher SVO2. This is very weird. If you notice this, yeah, it's actually very weird, because all other causes of shock actually causes less SVO2. Because let's take an example, hypovolemic shock. Like hypovolemic shock, if you have less volume in the body, you have less perfusion and less amount of blood flowing. This means that the tissues are not getting that much blood, right? And they're not getting that much perfusion. So they will use up every bit of oxygen that they can. And they decrease the amount of oxygen there is a lot. And that's why you have less SVO2. And all other also causes can cause low SVO2. Like, as an example, hypovolemic shock, obstructive shock, cardiogenic shock, all of them have less cardiac output. Here, less cardiac output. And you have less perfusion. This means you use up all of the oxygen that you have, and then you cause less SVO2. Yeah. So the only way to get higher SVO2 and also lower systemic vascular resistance is in distributive shock. If you notice here, the only reason to have lower systemic vascular resistance is actually the distributive shock, and also the only way to have higher SVO2. That's it. Next thing is, let's see what happens. And since you dilate the vessels a lot, dilation of the vessels a lot, let's see the original thing. This is the normal vessel walls, and when they are dilated, they look like this: big diameter and big dilation. And when they dilate, by the way, they increase the spaces between the endothelial cells. And this actually will allow more blood to escape from the vessels out to the tissues and create what's called edema. So now even the blood is escaping the vessels and creating edema in the tissues. And this means you have less blood volume inside here. It's very, very dangerous. So now we have hypotension from the dilation itself. We have less volume in the vessels itself. This means when we measure let's see what happens here. So the amount of volume will be flowing in the veins will actually be low because all of the blood, the volume is now in the tissues and in edema. So you have less volume left in the veins, less volume reaching the right side of the heart, and less volume reaching the right atrium. When we measure the central venous pressure, it will be definitely lower. Next thing is less blood flowing into the lungs, less blood going to the pulmonary capillary wedge pressure here. So if we measure the pressure here, it will be also low. And coming right up is the heart. So one important concept is cardiac output equals stroke volume multiplied by heart rate, and also the blood pressure. So blood pressure is equal to, depends on two things: cardiac output and systemic vascular resistance. So if you decrease the systemic vascular resistance, and this creates a very dangerous hypotension, our sympathetic system will be activated and will try to compensate things, and it does so by increasing the cardiac output. And also, by the way, when you dilate the vessels, this decreases the afterload and makes it easier to push blood and will create even better cardiac output, right? So this will maintain the cardiac output at first and acutely. So we have higher cardiac output. That's why we have higher cardiac output here. And also we have higher SVO2, if you remember, but lower systemic vascular resistance. And with time, again, you have less blood going from, less blood reaching the left side of the heart, and less blood less blood volume, mainly because you have a lot of edema. This means eventually this will affect the stroke volume, and it will go down, and actually will affect also the cardiac output. It will go down eventually, but at first it will stay up to be able to compensate. That's it. And that's it. Actually, we're done with the very, very confusing and annoying errors of shocks. Last thing is, I want to review what happens in the first aid. Let me just remove all of these and then get to the table of the first aid. So the table of the first aid is the same as we just discussed, but just compiled in one big table, so it will help us as a way to recap what we just did. And again, it's all about understanding what's going on. If you understand what we just did, you'll be able to crush any question that you will face on shock. So let's see, what are we dealing with here? So let's see. So let's just put it here. Let's begin. And then let's begin with, at first, the hypovolemic shock. Hypovolemic shock caused by either hemorrhage, either like dehydration, burns, whatever it's caused by. It's mainly just causing less volume in your body. Less volume, so you will have less central venous pressure. You will have less blood flowing to the lungs and less flowing to the pulmonary veins, so pulmonary capillary wedge pressure will go down. Also less blood reaching the left side of the heart, so low cardiac output, and the body tries to compensate by increasing systemic vascular resistance. And that's why when you increase systemic vascular resistance by the sympathetic activation, it will cause cold and clammy skin. Sympathetic system controls the the vessel tone in the skin. Also it controls the sweating, by the way. When you are activating the sympathetic a lot, it will cause a lot of sweating. That's why we sweat out of fear, right? That's it. And of course, you have less systemic SVO2 and saturation of oxygen because you are consuming all the oxygen there is. You're not getting perfusion and you have less cardiac output. So the tissues are now getting all the oxygen that they can from this. It will decrease the SVO2. That's it. Let's move on to the cardiogenic shock. It's a problem with the left side of the heart. So the main thing that you have to focus on is pulmonary capillary wedge pressure, because it's very, very specific. And of course, the main thing is, or main insult is in the left side of the heart. It's mainly decreasing the cardiac output. So since you are decreasing cardiac output, this will result in hypotension, of course, and hypotension will activate the sympathetic system to try to compensate, and it compensates by increasing systemic vascular resistance, so also cold and clammy skin. And this means blood won't just sit there, it will accumulate and backflow to all the other, accumulating backward. This creates more blood accumulation in the pulmonary veins and increase in pulmonary capillary wedge pressure. Again, it's a very, very important concept. And also accumulating in the central the right atrium and the right side of the heart, which creates a higher central venous pressure. Last thing is, since you have less perfusion overall, you will extract all the oxygen that you can from it, so you will create less SVO2. That's it. Next thing is obstructive shock, and we have a little bit of variation here. We have a lot of causes of obstructive shock. It's mainly, again, it's obstruction, and obstruction on the way from the right side of the heart into the lungs. But yeah, it's maybe done by pulmonary embolism, like an embolus here in the pulmonary artery, and preventing blood from getting from the right side into the lungs. Or tension pneumothorax, something in the lungs itself that just crushes the lungs and prevents blood from flowing from the lungs into the left side of the heart. It's all the same concept. Also, cardiac tamponade. If you have something, cardiac tamponade means you have a pericardial effusion or some fluid around the heart. This is the right atrium, right ventricle, left atrium, left ventricle, and this is the septum in between. And this is like the pericardium here. So in cardiac tamponade, you have a lot of fluid outside, and this fluid is pushing on all the chambers of the heart. So also, since it pushes on all of the chambers, it actually prevents blood from getting in or getting out. So it prevents both. It prevents blood from getting in and getting out. Getting in and out. So let's just keep it right here and then get back to it after we finish this. So essentially, in obstructive shock, since you obstruct away from the right side of the heart into the left side, into the lungs, or the right side, the left side, so you have more accumulation. Less blood flow into the lungs and the pulmonary veins. So pulmonary capillary wedge pressure should go down, and also less blood goes to the left side of the heart. So cardiac output goes down and causes hypotension. So it will activate sympathetic system, will increase the systemic vascular resistance. And yeah, this is, by the way, I think this is a mistake. It's not really. I'm not sure if it's right. I don't really agree with it. I think it should be low as the rest, because again, you have less cardiac output and less perfusion. This will make or force the tissues to use up all the oxygen that they have, and oxygen saturation should go down. Next thing is, since blood isn't flowing forward, it will accumulate backward and will create accumulation more in the right atrium and increase right atrial pressure. So central venous pressure is up. Also, this is the main concept of obstructive shock. We have another variation, which is cardiac tamponade. Cardiac tamponade also does the same. You have a lot of fluid outside and preventing, again, blood from getting in or getting out. So preventing blood from getting out, which means low cardiac output here. So low cardiac output, which will also activate the sympathetic system and increase systemic vascular resistance. Yeah. But the interesting thing is, and since blood can get in, it will accumulate all over. So it accumulates in the lungs, in the right side of the heart, yeah, all over, and essentially mainly on the right side of the heart, and increasing the central venous pressure. But the interesting thing is, since you have a lot of volume pressuring the heart, let's see it here. So again, you have a lot of volume pressuring the heart, and it will pressure left atrium. This creates more pressure in the left atrium, which will also equal the pressure in the pulmonary veins. So you have more pressure in the pulmonary veins, which means you have high pulmonary capillary wedge pressure. That's it. And that's the main difference here. In pulmonary embolism tension in pneumothorax, you had low pulmonary capillary wedge pressure, but in cardiac tamponade, on the other hand, you had more pulmonary capillary wedge pressure. That's it. And of course, since you have low cardiac output, you will have less perfusion, which will force the tissues to use up all the oxygen and will create less oxygen saturation. Last thing is distributive shock. Distributive shock, from the name, you are injuring the vessels by a sepsis, by anaphylaxis. All of them causes a severe sort of vasodilation, and also it damages like the mitochondria and prevents it from extracting oxygen from the tissues. So let's see, systemic vasodilation. The main thing is here. This is the main result: decreasing systemic vascular resistance and creating hypotension. And this will force increase the sympathetic system and increase the cardiac output to be able to compensate. So you have high cardiac output as a way at first. Then, but this is, by the way, the first stage, because after a while it will decrease. And since you have a lot of edema as well and decreasing the blood volume, so this will create less central venous pressure, also less pulmonary capillary wedge pressure, since you have no blood volume inside. Yeah. And again, since you have less pulmonary capillary wedge pressure, less volume getting into the left side of the heart, so eventually it will result in less cardiac output, but acutely it's high. That's it. And of course, you are injuring the mitochondria, so the mitochondria can't extract oxygen, so the oxygen saturation will be higher. This is the only way to get a high SpO2. Yeah, that's it. Last thing is, we have also a slight variation, which is a CNS injury. And the CNS injury means like something like a neurogenic shock. And by the way, see our CNS, it maintains the tone, two things. It maintains the tone of the heart, and also maintains the heart function itself, or the heart rate. So if you have a CNS injury, it's easier to think about it this way. When you have a CNS injury or CNS insult, it will result in more parasympathetic activation, and it takes over. So this will create a very severe vasodilation, also will actually depress the heart or relax the heart more. It decreases the heart rate. Yeah, and that's why we have less cardiac output and less systemic vascular resistance. Yeah, it's not high cardiac output as the normal septic shock, as an example. Yeah, and also since you have a lot of edema as well, this will create less central venous pressure and less pulmonary capillary wedge pressure. And yeah, it also injures sometimes the mitochondria, so it's either normal or high SpO2. That's it, and we're finished with shock. Again, it's all about understanding what do you deal with and the pathophysiology and what happens in all of these scenarios, and it will get you questions easily. Because, by the way, if you try or even think about memorizing the arrows, definitely in exam you will get something wrong, because you have a lot of arrows in the exam, in endocrine, in cardiology, in pulmonology, in everywhere. So it's just fucking it's crazy to sorry about that. It's crazy to memorize all of these things, because you will definitely have something wrong and will miss something. So you have to go step by step just to be able to deal with the arrows. Yeah. So one last thing is here, by the way, I forgot to mention, which is when you have a less systemic vascular resistance, since you are dilating the vessel, like as an example, if you dilate like the skin vessels, this will get in more blood and will cause flushing and maybe worm skin. When you have more blood in, this will create more flushing and more worms in the system. And by the way, this is very, very interesting because and very actually practical. It's a practical way to know how much blood we have in. Like it's like we being detectives or Sherlock Holmes, like seeing like the skin or feeling the skin is just enough for us to get an idea about how much blood do we have in. It's very, very crazy concept. Yeah, that's it, and we're done. I encourage you to just go deep and go in any question that you want in your world, and you will definitely crush it. And that's it. I'll see you in another video or concept, and have a good day. Bye.